Welcome to session 9 of day 2 of RIO 2025, where the focus now is next generation LAAC precision closure with foam and flexibility, an incredibly hot topic if we look at the growth of these procedures around the world and particularly in the US. We're very lucky to have one of the great exponents of this in a case discussion session, who's going to be presented by Devi Nair, our operator. I'd also like to welcome our panelists, Bradley Knight from Chicago, US, and Shephal Doshi from Santa Monica, US. But Devi, now it's over to you.
Thank you, Richard. Can I have my slides, please? All right, well, thank you. So I'll be presenting on the class Accuform system. These are my disclosures. So just to introduce the system, like Richard said, this is a conformal system. It's the device is called the Accuform device. It has two sizes. It's a conformable implant with a nitinol endoskeleton. It has this foam matrix body and radiopaque marker bands that allow you to visualize the device on fluoroscopy. The device is covered with an EPTFE cover and has a flexible tether. So unlike a core wire that we see with the current generation device or the current commercial devices, this one has a flexible kind of tether. Now, as I said, the implant sizing is very easy because it does come in two sizes. There's a regular size and a large size. And what you'll see is both those sizes only require a very shallow landing zone, so about 10 millimeter in depth that is required. So even for those shallow appendages, you could consider these devices. Now, when you look at these two sizes, about more than 90% of the patients you could address with the regular size, and it covers an LA ostium range anywhere from 10 to 33 millimeters. And then you can see, of course, the very large appendages that range from 20 to 40, you use the larger device. Now, one of the things about the anchoring system, the system did undergo some recent changes. This is a newer version, the Accuform device, and what was changed was the anchoring of the system. So now there's two rows of anchors. The distance from the shoulder to the anchors really does not change with the compression. So the idea is that the foam expands and conforms to the appendage, and the two rows of anchors are able to engage the tissue. And you can see the different set of anchors, the first two being the two commercial devices in the US, and then on the far right is the older version of the class system, and the class Accuform device is a smaller or shorter anchor that allows for less collateral, better anchoring in this dual row anchors, but also potentially less collateral damage and less injury to collateral structures. And the idea is only 50% reduction of exposed anchor. Now, regarding the clinical trial, there's quite a bit of clinical evidence that has been collected validating the system. And you can see some of including the early feasibility study. There was an ICE study, there was a pivotal study in the US, and the GLADE study. But mainly what I would say that is going to generate the most evidence is going to be the CONFORM IDE pivotal trial that's currently happening. It's a randomized trial against the class Accuform device versus a commercial device, either the Amulet or the Watchman device. And it does include up to 100 centers and some out of OUS centers as well. And of course, the patients will be followed up to 5 years with 45-day initial implant imaging. And what I'll do is I'll show a case that's an edited case from one of the patients that was actually randomized to the conformal arm of this pivotal ID trial that we implanted. So if you could maybe show the video, that'd be great. And I do not plan to move to Mount Sinai yet. There you go. So there you go. So this is, for the study, we actually do pre-implant imaging, and that's part of the requirement, mainly to make sure that the system or the patients that are randomized are able to get a commercial device as well. So they have to meet criteria to get either a Watchman or an Amulet device to be able to be enrolled in the trial. And you can see per the protocol, the implant is done under TE guidance, and you can see the measurements. And again, as I said, the sizing is very simple. So most of the sizes are usually regular size. In this case, it was about a 24 millimeter ostium, so we ended up using a regular size device. I usually get access with ultrasound. I pre-close all of my LA closure cases. These are pretty standard steps for me. The transeptal, again, very important because you want to have a very coaxial entry or trajectory to the appendage. So here you can see I'm coming in the bicaval view. This is a anteriorly directed appendage, so we're coming in a very inferior mid approach. And under TE guidance, I'll get into the appendage. And you can see I don't usually use the pigtail. That's a VersaCross loop. That loop is about 24 millimeters, pretty similar to what we sized on the TE. And you can see how the appendage, even though on the TE it had that nice anterior turn, on fluoroscopy in this RIO caudal, you're seeing a little more posteriorly directed appendage. So the sheet I'm using is a multi-flex sheet, which is a commercially FDA approved sheet, which allows for deflection in multiple planes. So not just extension and flexion, but also anteroposterior deflection as well. And this is not part of the conform protocol. This is it's a sheet that's available independently, and we've combined it with the conform Accuform device for these implants, mainly because we want to try to land this device in a very optimal position, and being able to deflect the sheath. And I'm a proponent of deflectable sheets for LA closure to optimize this implant. So you can see what we have done is we've unsheathed the device. You can see those little radiopaque markers at the tip that exposes the foam tip. And what that does is it makes it very traumatic to enter. And you can see in 3D TE, I'm entering the appendage, and I like to enter the appendage in a very coaxial fashion. And the idea is that you have this very echogenic foam tip that we're entering with, so that makes it very traumatic. You don't really have to gain a lot of depth. You can see I'm somewhere in that within that 10 millimeter range. Remember that all the depth that's required is about 10 millimeters. And right about once I'm past that 10 millimeter level, I will start slowly unsheathing the device. And the key is that this is a conformable device, and it's foam. So you want to make sure that you, as you're unsheathing, you're allowing this device to open up very slowly within the appendage, allowing that foam to kind of engage and conform within the appendage, and kind of get, I would say, contact points and proximity to the left atrial appendage wall, and allowing those anchors to kind of nicely settle in. So it's a very, very slow, controlled deployment. And you can see I will steer with that sheet. The sheet has both anteroposterior deflection and also those little black knobs that allow for AP and lateral deflection. So I'll kind of deflect the sheet to where it aligns me very coaxially to the appendage. And you can see as I'm deploying on the TE, on that biplane view in the bottom below the 3D, you can clearly see the device kind of coming in. And you can see now the device is deployed. You can see those radiopaque markers. And what we're doing here is we're kind of letting the tethers be a little bit loose. There's no core wire bias because there's no core wire here. It's just tethers. So you don't really have any bias. Once you've deployed the device, it's almost that you have the tether just holding the device in place, and there's really no pull on the device. So you really get to see the device in its free nature, for that matter. And if you look at that 3D TE, you can see the device occluding the appendage, and you can see it in the biplane view as well, right at the level of the orifice, again, showing a very echogenic device. Now, one of the things that I absolutely love about this device is that it is very occlusive. Because of the foam and because of that EPTFE, it is very occlusive. So very, very easy to check for any kind of, or any leak, for that matter. So, of course, we're doing color. We do color assessment, make sure the device is in a good position. We do do go through the criteria to make sure that the device is optimal, and we'll go through the entire plane. But what you're seeing on the angiogram is what I was talking about, how occlusive the device is. So when you do an angiogram, unlike a Watchman or an amulet device where the contrast could go through the fabric, and you kind of have to think about whether it is through the fabric or it is a peri-device leak. With this device, because it's so occlusive, you really know from the get-go whether you have occlusion or not. There's really no question to it. And once you have kind of met that criteria, which you can clearly see it was in a good position and had good occlusion, you cut the tethers. So it's a long tether that comes through, hooks within the device and comes out. So you cut one end of the tether and you slowly kind of pull that whole string of the tether out. And as you release, you're seeing that we're watching it under fluoroscopy. We're watching it on TE to make sure that the device is stable as we're releasing the tether. And it's, again, as I said, it's a pretty slow process of releasing the tether, kind of going with the heartbeat, just one beat at a time. And of course, once you've come through that one whole length or one pass of the tether, you'll see me kind of pull it faster because now I've kind of released the device and just taking out the final end of the device. So, one of the things I will say is if the device, say, was not in an ideal position, the device can be recaptured and repositioned at a more ideal location as needed. And of course, because the device is very conformable, you can put it in a more proximal plane as needed. Now, once I've released the device, I like to do a final angiogram, and you can see now this is a released device. You can see that LA angiogram clearly showing a nice occlusive appendage, and also on the TE where the device is sitting very nicely with that EPA-TV covering in front. And of course, in the trial, we're doing DAPT for 6 months. These patients will get imaged at 45 days to look for any leak, and also will be imaged at 1 year for further imaging. So I'll get it back to you, Richard, to have some discussion on this device.
Brilliant. Thanks, Devi. One thing I notice is that you're using TOE rather than ICE. Is there a technical reason for that? Is that better for looking at the appendage, or?
This is a great question. So the reason we use the TOE in this video is because it's from the IDE trial, and the trial does require the use of TE imaging because that is how most of the IDE trials have been done in the U.S. But having said that, there has been the GLACE study, and there has been the pivotal study that looked at feasibility of implanting this device just with ICE and just fluoroscopy, and it's absolutely feasible. As I said, one of the things is on fluoroscopy, you can clearly see if the device is occlusive or not. So you're not as dependent on imaging or TE or ICE imaging, except for transeptal and entry into the appendage. To me, I think this could be done very well with just fluoroscopy and minimal imaging. And by the way, Shephal Doshi is one of the national PIs for the study, and I know he's joined on the panel as well.
Well, that's why I'm going to ask him my next question, actually, Shephal, about the trial. You may not be surprised to know that in the UK, we implant about 300 devices a year in the entire UK. So it really hasn't gained traction in the UK. And I think there's quite a lot of skepticism about the data as to whether these devices, whoever the manufacturers are, actually do have a significant benefit or even are equivalent to anticoagulation. And I was just wondering why the trial was designed to compare against another occluder rather than against a DOAC. Is it because now it's just not possible to recruit patients to that sort of trial? Can you comment on that?
Yeah, no, great question, Richard. Thanks for having me. I think the challenge, as you said now, would be akin to doing an ablation trial and randomizing patients to drug. Most of the patients that are implanted with these devices have some sort of relative contraindication anticoagulation, even in the US. So to have patients who have challenges being on anticoagulants and randomizing anticoagulants is a tough scenario for enrollment. Now I understand there's some skepticism, and in 6 months, or probably in 3 months or so, we will hopefully present the data from the Champion AF trial. But what's interesting is the comment you make about the limited number of implants in the UK, for example. I mean, right now, the patients that are typical candidates for appendage closure are those patients who are intolerant of anticoagulation. And that being said, people want a study to prove it's equivalent to anticoagulation, when in reality, we're looking at patients who can't even tolerate it or are not compliant with it. So it's a little different from what we're studying in terms of who's being implanted, at least in the United States.
Yeah, I mean, that's a really good point that, we're restricting it to a very limited number of people, but then we're expecting the trials to be comparative to DOACs. That brings me on to Bradley, because I'm really interested, Bradley, with the the number of implants is exploding around the world, apart from the UK. Can you just give us some insights into who you would prescribe these types of devices for?
Well, left atrial appendage occlusion devices in general, I recommend it, as was discussed, for patients who have intolerance to oral anticoagulation, and that's a large group of people. I do acknowledge there's a big gray zone. There's people who have absolute contraindications to anticoagulation. They've had an intracranial bleed, et cetera. And then there's the people who have much less objective absolute contraindication, people who prefer not to be on it, patients who have to take nonsteroidals for their arthritis, patients who have had repeated falls and contusions. So I think there is a large group of patients who are kind of in that gray zone. The concomitant issue, I think, is a new driver for left atrial appendage occlusion. It's now an option for patients who, when you tell them they're going to have an ablation and they may not be able to stop anticoagulation, it's very appealing to consider having a appendage occlusion at the same time. We don't have time to get into it, but I think the Ocean trial that just came out might challenge that approach. But I do think that there's room for, specific to this presentation, better or different alternative left atrial appendage occlusion devices beyond what's currently available. And I just wanted to ask Debbie, if that's okay, can you talk a little bit more about the characteristics of the device? You said it's a very slow deployment. At what point, like after you've created a flex ball and you can move it around, once you start deploying it, you can't really move it? What's this like to recapture, and at what point can you not reposition it?
So I think it's a great question, because I do a slow deployment for every device. I feel like it's important to give the device time to kind of engage the LAA tissue. But I will say that with this device, I actually go a little bit more slower, and I'm curious to hear how Shephal does it. He's also done quite a number of implants. But I like to just do a slow deployment because, number one, it's a very short device. So if you just let it pop out, it's just going to pop out. Whereas if you do a slow deployment, that foam gets to, as it comes into the blood pool, it kind of expands and kind of engages the tissue. That endoskeleton now gets to take that shape, and those anchors now get to engage within the appendage. It can be recaptured. I've recaptured it up to two times at most. Not that I potentially could do it more, but the idea is that once you are in what I showed you, with the little bit of exposure of that foam tip, I call it the bumper. So you can move within the appendage in that bumper configuration very safely because it's very soft. And then once you start deploying, midway through, if I don't like it, I'll actually recapture it back and bring it back to where I need to. So that's not been as big of a challenge for me.
I think when you think about the construct of this device, Brad, the devices, whether you use a regular size, which again, you're looking at a mean diameter, because this device can compress. It can be 31 on one end and 15 on the other because it's foam. So what happens is that whether you use a regular device or a large device, the device's depth of night null is only 10 millimeters. So beyond that is foam. So the back end is a soft kind of bumper concept. And so it's not exactly the same as a flex ball, but even as you're deploying it, as the device starts to open, you still have the ability to swing it if you aren't making contact on the wall. So there's still maneuverability, knowing that half of the device 5 millimeters beyond that is just foam. So the nitinol is kind of short, so this is ideally suited for many of the short appendages where even though you have a wide device, the depth required is still the same. 10 millimeters is the depth that you would need. And similar to the other devices, you would resheath it to recapture it and then unsheath it to redeploy it. So that concept still holds. A little different when you have a fabric tether versus a metal tether, and a tether that you can't see on fluoroscopy, that you really would see with imaging if you want to look at a tether.
So can I just follow on from Bradley's question to you, Shephal, then? What situation would you use this? Would you use it in, presumably it works just as well for long appendages as well. So do you use it for everyone, or are there other devices that you think are better suited for different anatomies or different patients?
Well, I think that's still something we have to understand. It's just like the days when we started having CS leads. We say, well, maybe this shape is better suited for this branch and this shape is better. And then in the end, you end up, they kind of all seem to work for most of them. So I think, yes, there are certain scenarios where if you have a really shallow appendage, this might be the one device that fits. But I think the unique aspects of a device like this is the fact that it's completely occlusive from day one. You're not waiting for endothelialization, which may or may not happen years down the road. And there is generally a one size fits most. It does handle well with a deflectable sheath. And as Debbie said, I think one of the unique aspects is imagine a time when you're not as dependent on all this complex imaging. You have imaging to get transeptal, you have imaging to get you to the ostium, then you do an angio or two, and potentially it could be a much simplified implant. But I do think that at the end of the day, most devices that are commercial should work for most anatomies, having a few niche criteria for certain specifics. But in general, I think they would fit well for most. It's just really workflow and simplicity that's going to define the differences between the ones that are out there.
So Bradley, you laid yourself a trap, which I want to ask you a question about. Tell me about what you think about concomitant LA appendage occlusion. Do you think that's should be the standard of care for everyone, or who should be the patients that we should think that this is a good thing to do concomitant with AF ablation?
Well, that's not a quick answer, but I think that for patients who are good candidates for left atrial appendage occlusion and for catheter ablation, doing it concomitantly is very appealing for patients. It's now reimbursable to some extent in the United States, so it's become more commonly done. I do think that there are many patients who can undergo catheter ablation and after several months or a year of monitoring do not have atrial fibrillation, are probably reasonable candidates to stop anticoagulation. So I offer, it's very appealing for patients. The patients for whom I've offered the procedure are people who come asking for it. So it's something that patients are aware of.
And Devi, you hinted at the sheath that you use for the system, for the foam system, is not the one that comes, it's not provided by the company. And because one of the things I struggled with when I was doing LA appendage occlusion is the sheaths were horrible and just weren't shaped to be coaxial with the appendage. Can you talk about the sheaths and delivery systems that you use and how you use them?
So as I said, Richard, I'm a big fan of deflectable sheets. And I use deflectable sheets for my Watchman implants, for my Amulet implants. And with the conformal system, the sheet that currently comes with it is a non-deflectable sheet. So again, sticking to my practice, I like to just be able to have, the most optimal implant. To me, I think one of the biggest Achilles heel for LA closure today is peri-device leaks. And unless we are able to put the device during the implant in a very optimal site, and I also want to minimize the number of recaptures, et cetera, for the device, I think to me, the deflectable sheets make a huge difference. I think it's a game changer to me to be able to, orient it, enter the appendage in a very coaxial fashion. I'm not tilted in one direction or the other. And then this particular sheet is called the Multiflex sheet or the Vizaramet sheet. It does have approval in the US. And the advantage of this particular sheet is something I use for many other things as well. just not particularly just LA closure, but it can go proximal. It has a flexion, extension, but also has these little knobs, the 4 knobs that actually take it in kind of the 4 different planes as well. So it's got a proximal as well as a distal deflection capability. So it's almost gives you a lot more functionality. In some cases, I will say that, say if your transeptal is a little bit off, I would say that as long as you're inferior, but say you're a little bit off anteroposteriorly, these deflectable sheets kind of help correct that as well. I would not advocate deflectable sheets for a bad transeptal, but still, I think if you're inferior enough, I think they help you get away with a lot of those implants safely as well.
Richard, if I can just
Well, I'm
add
gonna-
just a clarification, just in the clinical trial, this deflectable sheet multiflex is offered as an alternative for the implanters that want to use deflectable sheets. And we're encouraging the implanters to try to use deflectable instead of going with the straight sheet. So it's offered as part of the study.
Well, I'd like to finish with giving you the last word, Shephal, about the study. When do you anticipate we see some results? And I'm going to be a bit naughty and ask you to predict, because you've got a lot of experience with this system already. What do you predict the outcomes are likely to be?
Well, I knew you were going to be a little naughty at the end of this, so I was prepared for that. But, I think, look, we're probably getting close to about 50% enrollment or getting close to that. And so we anticipate with more sites coming on, we're hopeful that we can finish enrollment in this trial by the end of next year. And then we're looking at a little over, a year to 18 months of follow-up, and then, presenting the data. So I think, at the rate we're going, this is end of 2025. So we're hoping in 2027 we'll have some answers. But I think generally speaking, the way we're doing these trials and randomizing to the commercially available devices, we would anticipate that unless there's some safety issue that we find out as we do more and more cases, which we haven't seen, but we would expect most of these devices to get commercial approval, at least at the experience that we have right now in terms of ability to implant, the safety data, et cetera. So I think the field is ripe for having, in the US, we only have 2 devices approved. And I think we just need to have more options so we can better suit our patients, using the right techniques that are appropriate for the patient with the given device.
So you've been incredibly diplomatic and above board. So I'm gonna predict for you, and you can just scratch your nose if you think I'm correct. So I think that it strikes me that this occludes better than the other devices, and so I suspect you'll see better acute occlusion rates. Whether that's good enough or significant enough to translate into better outcomes down the road, I don't know, but I suspect that that's probably what's going to come out of this trial. I won't ask you to comment and perjure yourself or commit yourself, but I'm so grateful to you all for a really good presentation and discussion. So thanks so much, and everyone stay online for our final session of the day on RIO 2025.
Thank you.
Thank you.
Nice case study.